So now we know what are the options we have in hand for OSA patient. So what happens when they don't respond to our treatment, whether it is soft tissue or skeletal? There are so many factors besides the outcome. It depends upon the severity of the clinical symptom and the severity of the disease, the BMI, and the level of collapse, single level or multi-level, associated comorbid conditions, and the lifestyle of the patient, substance or drug abuse, patient and family motivation, especially the patient's motivation, and the surgeon's expertise. So we broadly classify as objective and subjective outcome, not just AHA alone, as we were discussing. So you get two kinds of patients. Happy patients, though the AHA may not decrease or sometimes may even increase after surgery, but he is very happy with reduced snoring and improvement of daytime sleepiness. Unhappy patients with no subjective improvement but a distinctively lower AHA with the repeated PSG. So those kind of patients are very common in our practice. So we objectively define as successful patient, response, no change or deterioration. If you say for a CPAP using patient as a CPAP compliance, when a patient uses CPAP for more than 4 hours per night, for almost 70% of sleeping nights is considered significant and is good. Definition of success is still now it's being said by the value of AHI, that's Fujita's classification, Scher et al. And so many Larson, Janssen, so all were indicative of AHI values. The response is defined as improvement of AHI between 20 to 50%. If it is between 20% plus or minus, we change, say it is no change, because individual night-to-night variability can be there, plus or minus 20%. Deterioration, when there is an increase in of AHI of more than 20%, this also can happen. Sometimes after the surgery, it's stenosis or the patient puts on weight, extra, the treatment failure, we say. Newer concept is responders or non-responders. The responders is patient with who has success and who has response. Non-responders are both no change and deteriorating. There are various other ways, as I told you, not just AHI, quality of life measurement with short form 36 or OSA 18 quality of life questionnaire, child health questionnaire parent form 28 in pediatric OSA, Pittsburgh Sleep Quality Index. I'm not going to go in detail of everything, just to say what are the forms available whereby you can assess the quality of life, functional outcome of sleep questionnaire, and general health status was measured with SF36, mental component summary and physical component summary scales, daytime sleepiness, what we commonly use excessive daytime sleepiness, post sleepiness scale. So another important investigation what we can use is psychomotor vigilance task for assessing the cognitive function, where we can assess the reaction time, we can compare before the treatment and after the treatment. And what we were, Dipankar was discussing about the sleep goal, was brought up by Kenny Pang and Brian, about various values, not just AHI. So let us get into the topic per se. So what next after for non-responders? That means no improvement or deterioration. So after proper clinical evaluation and the history taken, that means so what surgery has been done or what CPAP setting is being used. I am comparing both CPAP users and post-surgery. So what surgery is being done. If you have a video of before surgery, directional sleep endoscopy or dynamic MRI, whether the surgery performed is sufficient enough or they have missed anything. So that all has to be properly evaluated before putting the next step of PSG, DISE or dynamic MRI. When do we do? Usually we do it after a gap of 6 months. If the symptoms are increasing, we may even do it at 3 months, or if it is really deteriorating, even at the 6 weeks we can do. Usually PSG level 1 or level 3. Level 3 is suffice, or if you suspect any other sleep disorder, level 1 may be advised. Rule out other sleep disorders, REM associated sleep AHI has to be measured. Central apnea has to be looked for, loop gain, and other comorbids like COPD, copper-pulmonale, hypothyroidism has to be evaluated. Sometimes CRP, leptin levels will also help you to assess the severity of inflammatory condition. So what next? So let's see patients with poor CPAP compliance. The most common problem is will be with the interface, intolerance to high pressure, dry mouth, persistent snoring, belching or fullness of mouth, stomach, feeling sleepiness or tiredness, claustrophobic, irritation, nasal irritation, rhinorrhea, nasal congestion. These are very common. So most common, as I told you, is the interface. There are various masks available. So we have to check with the patient what mask they are using, whether they are comfortable with the mask, full face or nasal pillows. So whatever is comfortable for that patient, we have to ask them to choose so that they will be comfortably using that. If the pressure is very high, so this can be assessed with the CPAP usage report, where you will be able to see the mean pressure, 95% median pressure on the highest pressure. So if it is more than 15 centimeters of water, usually they will be not comfortable with auto CPAP. If they are comfortable, fine. If they are not comfortable, then you can suggest them to use BiPAP, where the pressure during expiration will come down. If there is obstructive static component, remove that. There are so many literatures saying nasal surgeries, pelvic surgeries will improve CPAP compliance and reduce the pressure. As I told you, when you use BiPAP, the pressure during expiration will come down. Thereby, the patient can breathe comfortably. At the same time, the pressure setting can go up to 25 to 30 when we use BiPAP. Dry mouth is another common complaint by the patient. So when the patient especially sleeps in an air-conditioned room, so you can suggest them to use humidifier. Mask leak is another common problem which causes eye irritation or nasal congestion or persistent snoring. There's an air leak around the mask. So if there is a leak, if the patient starts using a very tightly fitting mask, it can cause nasal pouch ulcer. So there are various nose gel pads available which can be suggested. CPAP pillows, they may say I'm not comfortable sleeping on my supine position, so I want to sleep on my right or left, I'm not comfortable. So CPAP pillows are available where you can see depression for ear, depression for the mask, and contour curve and side supports are available which can be suggested. Chin strap, if the patient is not happy with the full face mask but the patient is sleeping with mouth opening, the pressure delivered by the machine may be a little high, may be required, so you can suggest CPAP, chin strap along with CPAP. So finally, what we want is actually he has to use with smiling face. So what we do after an unsuccessful OSA surgery. So as I told you, what is the preoperative DICE finding or dynamic MRI finding, what surgery has been performed, all those has to be evaluated. If you are not convinced that proper surgery is not being done, or even if the proper surgery is being done, there is a persistent OSAs, so re-evaluate with the PSG level 1 advised or level 3 can be done. If it is normal, that means the PSG value is still normal, but the patient is having a lot of symptoms. So you have to think of a lot of variables like if he is obese, lifestyle modification, if maybe he may be a sedative, he may be taking an antidepressants, or he may be medications on sedations. So lifestyle modification and medications is a must. And other sleep disorders has to be ruled out, like narcolepsy, REM sleep disorder, central apnea. So properly evaluate them and send it to your colleagues for a second opinion. And as I told you, COPD or lung restrictive disorders, IFL, send it to pulmonologist opinion, sleep medicine colleagues, and psychiatric counseling sometimes may be needed. And facial-maxillary opinion can also get the pediatric. If it is a pediatric age group patient, pediodontist opinion to be is must. If it is significantly positive, look for central apnea. That is also very common. If it is high, further evaluate the patient why that much of central apnea. And if it is not much of, after neurologist or cardiologist opinion, if it is fine, then put him on adaptive servo ventilator, or you can treat him with medication with the help of your colleagues, neurologist. If sometimes AHA is a combination of apnea and hypopnea. The apnea index might have reduced, but still they may be having hypopnea. So the value of AHA will be the same, or even sometimes may increase. So if the hypopnea index is higher, and if it is mild to moderate level, do ask them to do proper regular exercise, weight reduction, lifestyle modification, etc. Exercise, they will say, I am daily walking. So that's not an exercise. So ask them to do proper exercise to improve muscle tone in a workout in a gym, not just walking and walking around the flat and apart. So if it is severe hypopnea index, definitely needs further evaluation with dynamic MRI or DICE. If it is high apnea index, or if oxygen discharge index is also very high, further evaluate the patient with DICE or dynamic MRI. And if you can, if you really find obstructive events, then you can suggest them a CPAP or oral appliance on the surgery. If surgery, soft tissue, we classify as soft tissue and bony framework surgery. And if it is obese patient, we can suggest some bariatric surgery. And if it is soft tissue surgery, it may be a minimally invasive surgery or major procedure. All depends upon your DICE or dynamic MRI finding. So, re-evaluate them, counsel them if accordingly whatever I have discussed in the flow chart. If it is weight reduction and bariatric surgery, if the BMI is very high, lifestyle modification, exercise or myofunctional therapy, medication, sometimes anti-allergic medication itself will reduce the hypopnea levels, mandibular advancement devices, and even the option of revision surgery or CPAP. When there is an option of revision surgery, as I told you, it may be a soft tissue surgery or a bony framework surgery. If it is bony framework surgery, we have beautiful discussion happen, transpalatal advancement if it is palatal level obstruction, mandibular advancement if it's level of retroglossal advancement, or both maxillomandibular advancement. Hypoglossal nerve implant, but still not in our scenario, and not last but not the least, tracheostomy. So to conclude, PSG measures do not capture all elements of OSA and thus should not be exclusively used to evaluate treatment response. There are various other questionnaires to assess the quality of life which can tell you whether the patient has improved from OSAs or not. And should be noted that patients rarely present for cure for the AHA level. Sometimes the AHA may be increasing and he may be a happy patient. So other quality of life and other symptoms to be looked for. However, although not always curative, sleep apnea surgeries will often achieve enough treatment effect to require significantly less therapeutic path and making tolerance and compliance more favorable. A lot of literature in it. That means to compare autosclerosis after stepidotomy, it may not achieve the complete airborne gap closure, but definitely that will improve his hearing and he will be feeling much better. So that is your aim. You can't treat all the patients. Sometimes you may have to accept our degree. So the current research should aim to optimize and validate the other parameters to assess the surgical outcome.